Guys, we can start the session. Myself, Dr. Bandhala Rajan, your dermatology ADRPLEXUS faculty. Today we are going to see the previous year NEET-PG questions. Sorry, it's not 2013. It's 2013, 22, 21. 3 years recall. And you will see how the questions asked and what are the important topics you have to concentrate. In last 3 years, the pattern has changed. Initially, the questions are more of factual questions, one-liners and all. Now the questions are more towards nutritional deficiencies, STDs, HIVs, infectious diseases, and questions linked to two or more subjects, and mainly application-based questions. Mainly clinical-oriented questions are more. Out of which you will start with the easier thing, something like a nutritional deficiency. You could have read in biochemistry also, no? So we will see some diseases and we will see the questions asked in the exam. The condition is pellagra. They have given an image of hyperpigmentation over the neck and over the dorsum of hands. This is seen in pellagra, which is due to niacin deficiency. Vitamin B3. The main features are, yes, you are correct. The main features are 4 Ds. Dermatitis, diarrhea, dementia, and death. In the dermatitis, it is mainly photosensitive rash, mainly over the exposed areas. In the neck, it is known as you told correctly, it is castle necklace. The main causes of niacin deficiency are the people who is taking maize-based diet, staple food, alcoholism. Apart from that, it can be seen in heart nerve disease. These are some important points in pellagra. Next condition is there are given hyperkeratotic papules over the elbows and knees. Are you able to see? The elbows and knees. If you see these things in child, it is towards phrynoderma. Phrynoderma, or otherwise known as a taut skin. Taut is a type of frog. You will feel that dry, rough skin over that. So it's known as taut skin. Then mainly it is due to, initially it was thought only vitamin A. Now they are telling vitamin A, vitamin E, and essential fatty acids. Not essential amino acids, it is essential fatty acids. Okay, it is very, very important. Next, here a baby presented with rashes mainly over the perioral, perianal, perigenital, and acral rashes. The baby is having Periorificial. You can call it as periorificial. Both around the mouth, around the eyes, around the anus, around the genitalia. They are periorificial rashes plus acral rashes over the hands and feet. Along with that, if the baby is having diarrhea, alopecia, poor wound healing, we will think of a condition known as acrodermatitis entropathica. Means there will be a skin rash. Along with that, you will have a diarrhea. So it's acrodermatitis entropathica. It is due to zinc deficiency. The main mutation involved is SLC39A4, which is encoding. There is a zinc transporter in the gut. It will be mutated. Okay. This condition, one clue they will give. Like the baby presented with these lesions after 6 months. During weaning period, the baby will have lesions. Symptoms during weaning period means after 6 months. So these are the very important clues they can give. It's a high yielding topic and it can be asked this year also. Next one, there is a condition known as kwashiorkor. It is a type of protein energy malnutrition. So due to PM. In these two signs you have to remember. One is in the hair, another is in the skin. In the hair, as you told correctly, you can see different color shades, na? Different color zones. It look like a flag. So it is flag hair sign. Perfect. The skin, if you see closely, it is like a peeling of skin. Something like a old paint in the wall. So it is known as, anybody? Yes, correct. It is flaky paint appearance. Or otherwise known as crazy pavement pattern. Right? When we move on to some questions asked in the exam, you kindly put the option A, B, C. That's all. We will move ahead. A patient presented with diarrhea, dementia, and dermatitis. What is the deficiency? Yeah, basically they are mentioning about pellagra. The answer is vitamin B3 or niacin. Good. Next one question, they have given an image also. A farmer presented with loose stools and rashes over the sun-exposed areas. Careful dietary history revealed a history of diet rich in maize. What is the diet deficiency? Same question, but in a different way they have asked. So it is in niacin deficiency. It is also pellagra. Next, a child presented with night blindness, presented with following findings. What is the diagnosis? Yes, they have given a image. of keratotic papules over the elbows in a child with night blindness they have given. So it's basically vitamin A deficiency. It is pyrenoderma. Next question. A baby presented with perioral erosions, diarrhea, and delayed wound healing. Which deficiency lead to this? Yeah, it is zinc. Mainly acrodermatitis enteropathic. Acrodermatitis enteropathica. Right? Next question. This was somewhat a different question. It was asked in NEET-PG 2023. A baby presented with alopecia and following skin rashes. Baby is fed regularly with a raw egg. What is the association? The symptoms are not given in other conditions. No? So how to solve this question? Like they have given a clue like raw egg. If the person is feeding raw egg regularly, it will have avidin. Perfect. This avidin will lead to inhibit the biotin by making a combination. It will combine with biotin and inhibits the absorption and action. And we know biotin is one of the major part in many hair supplements. Na? So biotin deficiency can lead to alopecia. So it is biotin deficiency. The features given are hair loss, skin rash, conjunctival congestion. Just a few points about other vitamins. What is the vitamin C deficiency is known as? C deficiency. It is scurvy. Na? What is the mucosal manifestation they will have? There will be gingival bleeding. What will be the hair? What kind of hair will be there? Wound healing will be there, yes. That can be a clue. What kind of hair they will have? They will have corkscrew hairs. Something like this. Corkscrew hairs. C for C, you can remember. What will be there for vitamin B12 deficiency? B12. In vitamin B12, you will have a pigmentation over the knuckles, mucosa, megaloblastic anemia. In the skin, you will see of hands, mucosa. Apart from that, they will have a premature graying. Mainly seen in vegetarian diet. Okay. These are the important points in nutritional dermatosis. Shall we move further? Yeah, other clues they can give peripheral neuropathy, megaloblastic anemia, and yes. Next, we'll move on to infectious dermatosis. In the infectious dermatosis, in the last 3 years NEET, they are mainly asked about fungal infections. Okay. This is very, very high important, high yielding. Okay, it was asked multiple times before also. A patient presented with cauliflower-like growths with following histopathology, what could be the diagnosis? First, if you see cauliflower-like growth, it is a verrucous growth, right? What is the image given? Yes. They can ask in different ways. They can ask what is the finding. They can ask what is the diagnosis. They can ask what is the causative organism. Yes. So, these are copper penny bodies. Are otherwise known as medlar bodies, or otherwise known as sclerotic bodies. It is very easy to remember. When you see copper, it is a color. So it is chromoblastomycosis. Copper means chromo. That's all. This Chromoblastomycosis is caused by two organisms. It is very, very important. It was asked before also. Caused by two organisms. They are Cladophylophora carioni, Fonseca pedrosi. These are two common organisms. Okay. Right. Next, other subcutaneous infections they can ask is something like this. There will be a swelling. There will be a sinus. And there will be a grain discharge. If you see all these things, sorry, 1 minute. If you see swelling, sinus, discharge, as you told correctly, it is mycetoma. This mycetoma can be due to two things. It can be actinomycetoma or it can be eumycetoma. Actinomycetoma is due to actinomadura species. Eumycetoma is due to Madurella mycetomi and other Madurella species. The main difference is this actinomadura species will have pale colored grains, white grains. This eumycetoma will have black grains. Okay. If you do histopathology, you will see a grain with fungal elements. Okay, that is very, very important. Yeah, please note of it. Next, a person is presented with such nodular lesions in a linear pattern along with such histopathological finding. What can be the diagnosis? Yes, along with that, they are having history of a person is a gardener. Yes, you are correct, perfectly correct. The diagnosis sporotrichosis or rose gardener's disease. It is mainly due to a fungus known as, what is the fungus? It is Sporothrix schenki. The cutaneous manifestations are there will be multiple nodules in a linear pattern along the lymphatics. Not along the trauma, it's mainly along the lymphatics. Along the trauma is Kovner's phenomena, that is different. Lymphatics, it is known as sporotrichoid spread. If you do histopathology, you will see such finding. Can you tell me what is the finding? Histopathological finding? You will see asteroid bodies. Yes, perfect, perfect, good. They are asteroid bodies, yes. Yes, na, yes for sporotrichosis, you can remember. Asteroid. Apart from sporotrichosis, there are other conditions which have a sporotrichoid spread. Can you tell me what are the conditions? A condition like nocardiosis, Atypical mycobacterial infection. Yes, you are correct. In the atypical mycobacterial infection, it is mainly swimming pool granuloma. These are the other conditions can have a sporotrichoid spread. Yes. Yeah, please note of it. So we'll move on. Next, this question was asked in 2021. There's a combination of mycology and STD. Like a female patient presented curdy white discharge. Microscope showed budding E cells with pseudo-hyphae. Which medium is used to differentiate the species of causative organisms? First, we need to see it's a vaginal discharge. You know? There are three types of discharges you can see. One is curdy, another is green frothy, third one is white homogeneous. White homogeneous. If you see curdy white discharge, if you do KOH, you see pseudo hyphae, it is candida. If you do greenish frothy discharge, if you do wet mount, we using saline, you will see trichomonas. Anyway, apart from this, you will see a strawberry vagina. If it is a white homogeneous discharge, if you do wet mount, what you will see in wet mount? In white homogeneous discharge, you will see clue cells. It is of bacterial vaginosis. So in this case, we know it is a candida. In candida, candida albicans and non-candida albicans can cause the lesions. As you told correctly, the main differentiating feature is by chromogad. Because different organism is also different color. Albicans will have a different color. Glabrata and other things have different color. Okay. Which test you will do in bacterial vaginosis, as you told correctly. Good. Now we'll see a few things about candidiasis. Candidiasis is due to Candida albicans and other group of Candida, something like a Glabrata, tropicalis, cruzi, etc. Candida is commonly seen in patients who have diabetes. If the patient is diabetic, you will see these recurrent radial fissures in the glands and prepuce. Because in diabetes, there will be more sugar is excreted in urine, so there will be a more growth of candida in the genitalia. So they will have a candidal belnoprositis. And patients who are taking inhalational steroids, something like a asthmatic, what they will have a candida over the tongue and oral mucosa. So they will have oral candidiasis, otherwise known as oral thrush. The people who are sweat a lot, they are wearing tight clothes, they will have a rashes over the inframammary region, groin and all. That is known as candidal intertrigo. Just I am putting these images because any of these things can be asked. Okay, any of this scenario. But I am not getting what is the most common cause for balanitis. No, it is not a sexually transmitted disease. No, it is because of diabetes mellitus. This candidal balanopositis. Treatment is, I will tell you. The culture media for candidiasis is sabrodextrose agar for diagnosis. For differentiating, it is chromogar. Species by chromogar. Right? The treatment is mainly topical and oral antifungals. Control the diabetes mellitus. If you do KOH, you will see such appearance like multiple yeast budding yeast cells, and they will combine to form a pseudo-hyphae. Can you tell me in which fungal infection there will be a spaghetti and meatball appearance? Something like a short hyphae and group of spores. Yes, yes, it is seen in pityriasis versicolor caused by Malassezia papa. Perfect. Where will you see long branching septate hyphae? Something like a bamboo or sugarcane. Where will you see such findings? Out of superficial fungal infections, long branching septate hyphae. No, it is seen in aspergillosis, but in skin it is seen in all dermatophytosis infections. Tinea cruris, corporis. There you will see long branching septate hyphae. So 3 KOH findings you need to remember. Like pseudo hyphae with budding yeast cells, spaghetti and meatball, long branching septate hyphae, dermatophytosis. That trichophyton, epidermophyton, and microsporum species. Right? These 3 are very important. Right? These things can be asked in the exam. Next, the question was asked something like this. An asthmatic patient presented with whitish patches over the tongue. What is the treatment? What is the diagnosis? They're mainly telling about a oral thrush, right? If they ask such questions, first you see for a topical options, then you will see for a oral option. Out of these 4, clotrimazole is the only topical option, so that is the correct answer here. It is clotrimazole. Cotrimoxazole is different, clotrimazole is different, okay? The point with Grecia pulmonis, it is only useful against dermatophytosis. So that is also very, very important. Antifungal which is only effective against dermatophytosis is Grecia pulmonis. That is also very important. It is not useful in any other fungal infections. The correct answer for this question is basically clotrimazole mouth paint. Then these kind of questions are asked both in INI-CT and NEET. Like they will give a child of pre-pubertal age. You have to see whether the age is pre-pubertal. Pre-pubertal age with a painful swelling over the scalp, painful boggy swelling. Sometimes they will give a boggy swelling. With a pet dog at home. What is the diagnosis? Yes, most of you got it correct. Yeah, it is a Kirion. You should not confuse it furunclosis or folliculitis because they are having pus discharge. If it is a prepubertal child with a painful swelling, painful boggy swelling with the hair loss, you should think of Kirion. That is a type of Tinea capitis. So we will see something about the different types of Tinea capitis. I am not going in depth. Just I will tell the high yielding points. Like it is divided into non-inflammatory and inflammatory tinea capitis. The non-inflammatory types are grey patch and black dot. The colorful tinea are non-inflammatory or otherwise known as non-scarring tinea capitis. If other type is inflammatory tinea capitis, they are having a single name, something like a Kirion and Pavus. They are basically scarring tinea capitis. Scarring tinea capitis. In this, the organism varies. For grey patch, it is Microsporum canis. For black dot, it is Trichopeton tonsurans. You can remember easily something like a, if you tonsure the hair, if you see from the up, there will be multiple black dots and the same appearance will be there. So tonsure. If you do tonsure, you will see black dots, multiple black dots. Huh? So it is Trichopeton tonsurans. Then Kirion. Kirion is caused by Trichopeton mentacrophytes and Trichopeton verrucosum. Then the fourth one is Pavus. Pavus, it is very, very important to remember the causative organism is Trichophyton Schonley. The clinical features are, if you see grey patch, it is something like a seborrheic dermatitis-like lesions because it is ectotrichs. The spores will be outside the hair. So they will look like a lusterless dry hairs. The black dot, it is something look like this. There will be inside the hair, there will be spores. So it will be breaking easily. So it will have a broken hairs and black dots. Kirion and Pavus are easy to remember. Kirion is a boggy swelling. Pavus is a cup-shaped crust. They are known as putulum. One person is, I will tell you, the investigation of choice is KOH mount. Treatment is antifungals. One person is asked how to differentiate it from a cradle cap. Good question. The point is, here they have given a prepubertal age. Now, why tinea capitis is common in prepubertal age? Because in prepubertal age, there will be lack of sebum. So, no fungistatic effect. No fungistatic effect. So, there will be more fungal infections. But if they are giving a age less than 1 year means the baby will have sebum because of maternal androgens. So there will be more possibility of infantile seborrheic dermatitis. So if they are giving a age less than 1 year with the scaling over the scalp, it is infantile seborrheic dermatitis or cradle cap. Maternal androgens. So if they give less than 1 year, it is. So it's easier. If it is less than 1 year scaling over the scalp, you think of cradle cap or infantile seborrheic dermatitis. If it is more than 1 year, but within puberty, you think of tinea capitis. Are you able to understand this difference? Cradle cap and tinea capitis. I'll move on to the table again. Kirian is a boggy swelling. Favus is a cup-shaped depression. This is exactly opposite. That's all. So we'll move further. This was also a very favorite question for NEET-PG and NECT. A forest officer develops skin lesions as shown in the image. What is not the differential to consider? First, what is the skin finding given here? It is an Eschar. There is a black crust or Eschar at the tick bite side. Which condition it is not seen? Anybody? You're having a different opinion. Many of you tell it as carcinoma disease. One person is telling scrub typhus. You are telling scrub. In this, we have to see which conditions it is seen first. It is seen in cutaneous anthrax, so it is not the answer. Recluse spider bite, it is not the answer. You are done with two options. Only two are left. Among the typhus infections, rickettsial infections, only scrub typhus and rickettsial pox have the Eschars. So they are not the answer. So the answer is carcinoma disease. That is correct. Perfect. So you should know some list of infections where it is positive. The bacterial infection, it is mainly seen in rickettsial. As I told before, it is seen in scrub typhus and rickettsial pox. Apart from that, it can be seen in cutaneous anthrax. Apart from this, it is seen in any other bacterial infections. You will see in Pseudomonas infection. The condition is known as ecthyma gangrenosum. Okay. Ecthyma gangrenosum. In the fungal infection, it is seen in mucormycosis. This is very, very important. Mucormycosis. Apart from this, it is seen in recluse spider bite. There is a skin manifestation in disseminated intravascular coagulation that is known as purpura fulminans. And in severe CKD, chronic kidney disease or end-stage renal failure, you will see something known as you told correctly, it is calciphylaxis. These are the important points you can note down. Next, you will see something about papillosquamous and immunoblast, the very high-yielding questions. First, you should know the different nail findings of nail psoriasis and nail lichen planus. In nail psoriasis, there are multiple findings, but you should know two things. One is most common finding and most specific finding. What is the most common finding? It is this one. Coarse, irregular pitting. Correct. Coarse, irregular pitting. Can you tell which condition fine regular pitting will be there? Fine regular pitting. It is seen in alopecia areata. Okay. This is another MCQ. What is the most specific nail finding? As you told correctly, it is oil drop sign. Or otherwise known as salmon patch. Correct, perfect. Other nail paintings you have to remember are nail plate thickening, crumbling, subungual hyperkeratosis, something given here, na? Thick plates, subungual hyperkeratosis. And the nail plate will be separated from a nail bed, that is known as onycholysis. These are the findings of nail psoriasis. In the nail lichen planus, only two things you need to remember. One is something like a wing-shaped fold connecting the proximal nail fold to nail bed. What is that specific finding? The specific finding is, anybody? It is known as nail pterygium. It is something look like a eye pterygium, wing-shaped fold. Apart from that, you will see such nails, something like a pop tent nails. There are other findings in lichen planus also. One of the finding is in psoriasis the nail plate is thickened. Here the nail plate will be thinned out, thinned nail plates. So nail plates. That is one of the finding. Thinned out nail plates. Right? The most specific finding you have to remember in both sides. This is a question asked. A patient presented with irregular nail pitting and subungual hyperkeratosis and oil drop sign. They have given the clue also, they have given the image also. Both the things they have given. What is the diagnosis? It is psoriasis. Perfect. Next, you will see something about vesicular-bullous disorders, mainly intra-epidermal. Then we will see how to differentiate the immunobullous disorders by an algorithm. Okay. In intra-epidermal disorders, there are two things. Now, one is they are also known as pemphigus group of disorders. The pemphigus, there are two things. One is vulgaris, another is foliaceous. Now, one person is asking nail lacquer approved for onychomycosis. There are amrolfin, cycloprox. These are indicated. Okay. Now we will see this intraepidermal and pemphigus group of disorders. The autoantibodies are against. In foliaceous, it is very easy to remember. F for first. So everything will come as first. First or one, something like that. So the autoantibodies are against desmoglein 1. In vulgaris, it is desmoglein 3 more than 1. The nature of blister is same for both. It is a flaccid blister. In vulgaris, it is present all over the body and in the mucosa. But in the foliaceous, it will mainly involving the seborrheic regions. It spares the mucosa. If you do a Nikolsky sign, if you do a tangential pressure, there will be extension of bulla. That is Nikolsky sign. It is positive in all intra-abdominal blistering disorders. It will be positive. If you do bulla spread, if you press the center of the bulla will be extended. Something like this. If you press a bulla, it will be extended. It will be extended in an angulated manner in both vulgaris and foliaceous. Angulated or acute angle spread. Acute angle spread. In subabdominal, it will be a rounded edges. If you do Jang smear, what will you see? You will see acantholytic cells, something like a round cell with large nuclei in both conditions. What is the pathomechanism? These antibodies attack the desmoglein, so the cells will be separated because of loss of adhesion between the other cells. The polygonal cells will become rounded and acantholytic in both conditions. Main difference is the site of cleave. In vulgaris, it is a suprabasal split, something like here. Left with row of Thomson appearance. But in foliaceous, it is in the top first layer. First na F for first. So it will involve the first layer. So there will be a subcorneal split. Something like here. If you do DAF, both will have a fishnet pattern of IgG and C3. If it involves the all layers, entire layers are involved, it will be vulgaris, all layers. If it is involving only the top few layers, it will be foliaceous. These are the basic difference between two important pemphigus group of disorders. This is a question asked. A 30-year-old lady presented with flaccid bullae on her skin which easily rupture and crust. Biopsy revealed a suprabasal split. What is the diagnosis? If it is suprabasal, it is pemphigus vulgaris. If they are giving a subcorneal split, what will be the diagnosis? Yes, if it is subcorneal, it is pemphigus foliaceous. They can ask what is the autoantibody also. What is the autoantibody for pemphigus foliaceous? Autoantibodies are against desmoglein 1, na? I will tell a small approach to flaccid and tense bulla. It can be useful for your exam. Something like the bulla can be divided into flaccid or tense bulla. Flaccid means there will be wrinkles. Tense means there will be a shiny, taut, vesicular bulla. You will see. If it is a flaccid bulla, it is seen in intraepidermal disorders. In tense bulla, it will be seen in subepidermal disorders. Mainly, first we will see from autoantibodies. Or we will see from the diagnosis. Okay. The flaccid bulla can be seen in two things. One is pemphigus vulgaris and pemphigus foliaceous. The tense bulla, there are three things you have to remember. One is bullous pemphigoid, linear IgA disease, or CBDC will tell na, chronic bullous disease of childhood. Third one is dermatitis herpetiformis. If you see one by one, the anti-antibodies are for pemphigus vulgaris, it is desmoglein 3. For this one, desmoglein 1 for foliaceous, we know. For bullous pemphigoid, it is very easy to remember. It is BPAG 1 and 2 or BP 180 and 230. For linear IgA disease, it is linear IgA disease, LAD1. In dermatitis herpetiformis, it is mainly epidermal transglutaminase. These are the autoantibodies. If you see in the skin, it will be present in all actually. Both the conditions, there will be flaccid bulla. But in foliaceous, there will be mucosal involvement. But in vulgaris, there will be mucosal involvement, as we told before. In the Nikolsky sign, if you do in conditions like vulgaris and pollicis, it will be positive. Okay. You see the skin findings of subabdominal blistering disorders. In bullous pemphigoid, what you will see tense blisters with the urticarial base. You will see a red itchy base. In linear IgA disease, you will see something known as sting of pearl appearance. In dermatitis herpetiformis, you will see an itchy papulovesicles. Mainly over the elbows, knees, etc. If you see the mucosal involvement, it is less than 30% in both linear IgA and bullous pemphigoid. In dermatitis herpetiformis, it is rarest. If you do Nikolsky sign is positive in intra-abdominal disorders, but subabdominal disorders, it will be negative. If you do histopathology, pemphigus vulgaris will have a suprabasal cleft. Pollicis will have a subcorneal cleft. In these subabdominal disorders, both bullous pemphigoid and linear IgA disease will have a similar finding, that is subabdominal cleft. In bullous pemphigoid, there will be more eosinophils. Linear IgA, there will be more neutrophils within the cleft. Neutrophils. In dermatitis herpetiformis, you will see a specific finding known as papillary microabscesses. Right? For DAF, if we do, there will be fishnet pattern in intra-abdominal disorders. Mainly it is all layers, it is vulgaris, but it's only in the top layers, it is pollicis. Right? In subabdominal disorders, both bullous pemphigoid and linear IgA disease will have linear deposits in dermoabdominal junction, but if the deposit is IgG, it is bullous pemphigoid. If it is IgA, it is linear IgA disease. Okay, that is the differentiating feature. Next, for dermatitis herpetiformis, it is basically granular IgA deposits in papillary dermis. These are the very important points you need to know about the flaccid and tense bulla in a short. Right? Next, we will see some questions in STD and HIV. Okay. First, you should know this syndromic approach kit. In these few things, I intentionally left blank. Can you tell me? There are 7 kits from gray to black. Gray is for urethral discharge, white is for non-herpetic genital ulcer. Green is missing. You can take a screenshot. I will share anyway. Okay, no need to worry. So, can you tell me what is the green? Yes, you are correct. Green is for vaginal discharge. What is for red? Red is mainly herpetic genital ulcers. Black for bubo, correct. You can remember easily something like a from inside out. This is uterus, this is vagina, then external genitalia, abdomen. So, cervical discharge is kit number 1. Vaginal discharge is kit number 2. Third one is external genitalia. Na? So you can remember 3, 4, 5 are external genitalia. In this 3, 4 are non-herpetic. 3 is non-herpetic genital ulcer, 4 is non-herpetic sensitive to penicillin or allergic to penicillin, 5 is herpetic. Then you will go to little up, it is lower abdominal pain, that is 6. Then if you go laterally, it will be inguinal bube. In this, the kits you have to remember mainly is green kit, which is containing fluconazole and secnidazole. Then white kit. What is the content in white kit? Which drug is useful in syphilis? Yes, correct. It is having injection benzathine penicillin. 2.4 million units plus azithro 1 gram. So it is very, very important to remember because white kit is the only kit you will have an injection. Other kits have only tablets. Then another fill in the blank. Na? This is also very important to remember. The red kit content. Red kit is containing tablet acyclovir 400 mg 3 times a day for 7 days. It is the only kit containing antiviral. That is red kit. That is also one of the things you have to know. Red kit is the only kit containing antiviral. White kit is the only kit containing injectables. Blue and black are easy to remember. Blue and black are easy to remember because the kit is containing same drugs. Only difference is in the blue kit, the duration of doxy is 14 days. In the black kit for bubo, it is 21 days. That is the differentiating feature. So you can remember easily. A woman presented with multiple partners presented with a vaginal discharge. Examination showed some erosions or red spots in the cervix. Which kit to be used? Can you tell me what can be the diagnosis? There is a vaginal discharge and erosions in the cervix or red spots in the cervix. What is the diagnosis? First, you come to a diagnosis in this case. Yes, because vaginal discharge is there and some erosions in the cervix looks like a strawberry cervix. Instead of giving strawberry cervix, they are just putting erosions in the cervix. What is the diagnosis? It is trichomonas infection. You see trichomonas, what will be the kit? It is a green kit because there is a vaginal discharge. If many of you thought it is a cervical discharge, then the cervical discharge, what they will give? They will give something like a mucopurulent discharge or serous discharge with gram-negative bacilli. If they give such features, you have to think of grey kit. Sorry, gram-negative cocci. What is that gram-negative diplococci in cervical discharge? Gram-negative diplococci. Yes, it is gonorrhea. Perfect. Right? For this question, the answer is green kit. Next, I will tell you something about painful and painless genital ulcers. That is also very important thing. Can be asked in NEET. Very, very important. First, you will see painful genital ulcers. If you see painful genital ulcers, just to see the nature of the ulcer arrangement. If they are grouped or ulcers are in an opposing surfaces, something like a kissing ulcers. If you see grouped ulcers plus lymph node plus, it is herpes genitalis. Grouped or polycyclic ulcers. If you have ulcers over the opposing surfaces which lymph node positive, you have to think of chancroid. The investigation of choices for herpes genitalis, you will do Zinc. So you will see multinucleated GN cells. Multinucleated GN cells. MNGs. In chancroid, you will do gram stain. What you will see in grams? In chancroid, you will see spool of fish appearance. And we know the organisms, right? It is Haemophilus ducreyi for chancroid. For herpes genitalis, it is HSV2 that we know. If it is a painless genital ulcer, we need to see something. Whether it is single, indurated, or hard feeling ulcer, or whether the ulcer is beefy red, bleed on touch, or whether they will tell there was an ulcer, sir, within a few days it disappeared, something like a transient ulcer. If you have single indurated ulcer with lymph node positivity, it is towards chancre or primary syphilis. If it is a beefy red ulcer without lymph nodes, it is towards donovanosis. If it is a transient ulcer with lymph node positivity in a groove sign pattern, you know groove sign of above and below inguinal ligament, there will be enlargement of lymph nodes. It is LGV. The investigation of choices for syphilis, it is dark ground microscopy. For donovanosis, we will do GIMSA. You will see a bipolar safety pin appearance. For LGV, you will do serology. We know the causative organism now. For syphilis, it is Trichoderma pallidum. For donovanosis, it is Klebsiella granulomatis. For LGV, it is Chlamydia trachomatis. So this is very, very important to remember, okay? Like, this is the question. Anybody? Painless genital ulcer, painless lymphadenopathy. What is the out of these things have a painless genital ulcer and painless lymphadenopathy? In this, obviously, herpes genitalis and chancroid are out because they will have painful. They are painful. Granuloma inguinal or donovanosis having a painless genital ulcer, but there won't be any lymphadenopathy. So this is also one point you have to remember here is here you will see something known as pseudo bubo, not true bubo. Pseudo bubo is basically the infection will spread to inguinal region. Okay, so the answer here is syphilis. So if it is a painless genital ulcer with lymphadenopathy, there are two possibilities. Only in that syphilis is given. So syphilis is the answer. Next, a patient presented with painless genital ulcer, indurated genital ulcer. Motility of the causative organism is best detected by which microscope? Motility. Even without the history, they are asking only motility of the organism is detected by which microscope? It is dark ground microscope or dark field microscope. You will see corkscrew motility. In syphilis, okay. Right? Next, another MCQ in STD they can ask is the baby presented with molluscum-like lesions, means umbilicated papules. In the background of HIV. There can be three possibilities you need to think of. It was previously asked in the exam. If they are giving that molluscum-like lesions with lung symptoms, something like a breathlessness, hemoptysis, you have to think of something known as histoplasmosis. Another possibility is penicilliosis. Other name is Tanneromycosis. Tanneromycosis. If they are having CNS symptoms, something like a seizure, loss of consciousness, you have to think of cryptococcus. If they are having GN molluscum-like lesions, only skin lesion, you have to think of molluscum contagious. This was the question. Only they will have umbilicated lesions, no other findings. So what will be the diagnosis? No other clues they have given. So it is mainly molluscum contagious. Perfect. If they have lung symptoms, it is cysto. They give CNS symptoms, it is crypto. Okay. Mainly you have to think, see for associated symptoms. Next question. This was a very straightforward question. A HIV patient presented with following oral lesions, the diagnosis. You are having a purplish flocks in the palate in a HIV. You have to think of a condition known as Kaposi sarcoma. It is due to which virus? HHV number? Which number? HHV 8. Yes, perfect. This HHV 8. Kaposi sarcoma, herpes virus. KSHV also they will take. HHV 6, you are telling us somebody HHV 6, HHV 5. Which condition it will lead to? 5, 6, anybody? 5, 6 and all. It is related to Pityriasis rosea. Okay. Very important to remember. HHV 5, 6 are related to Pityriasis rosea. Next question. A patient presented with an anogenital wart with a histopathological features of squamous cell atypia, which high risk HPV can lead to this. High risk HPV. Which are the high risk HPV and low risk HPV? The low risk HPV are HPV 6 and 11. High risk are 16, 18, 31, 33. So the answer is HPV 18. What is the low risk and high risk means? High risk means there is a more possibility of squamous cell carcinoma. That's why it is known as high risk HPV states. Even in the history, they are given as squamous cell atypia, so it is a high risk HPV infection. The condition given here is condyloma acuminata, which is a cauliflower-like growth seen in HPV infection. Can anybody tell what is condyloma lata? Condyloma lata. What is condyloma lata? It is caused by secondary syphilis. Yes. They are basically lata means flatter lesions, flat, moist papules. Here it is something like this, na? There it will be flat papules, flat, moist papules. Flatter. Right? We'll have a 1 minute break or just 15 seconds break, okay? Yeah. Now we will see something like a leprosy, the important points in leprosy, okay? This was a question asked in 2022. Many people felt very difficult in this question. Like leprosy patient present with a hypopigmented patch over the center of forehead, which nerve is likely to be involved. Trigeminal, facial, trochlear, and abducens nerve. In leprosy, these single or few patches lesions, the tuberculoid pole lesions, they will follow the nerve distribution. So for this, you have to know what is the basic nerve distribution here. In the forehead, if you see, there are more of supratrochlear, supraorbital, and other lacrimal nerves. They are basically branches of trigeminal nerve. The cheek, if you see, you will see more of facial nerve branches. Something like a buccal nerve, zygomatic division, you will see. Those are the divisions. So since the lesion is given in the forehead, it is more in the distribution of supratrochlear and supraorbital nerves. So basically they are part of trigeminal nerves. So the answer is trigeminal. If they are giving something in the cheek, you may think of facial nerve. Many of them confuse trigeminal and facial because both are present in face. You have to see the distribution of lesions based on the image. Right? Next, this kind of questions can be asked. No, it is nothing to explain. You have to see the distribution of nerves. Where the nerve is basically presented. We know not supratrochlear and supraorbital nerves are in the forehead. So if a patch is present in the forehead, it is basically related to that nerve. Those nerves are derived from fifth nerve. So fifth nerve is the answer. If the lesions are present in the cheek, the nerves prominent here are facial nerve. So facial nerve is involved. You see the image and see the location of the lesions. Right? Next, this is very, very important question. A patient on MDTMB presented with worsening of pre-existing lesions with nerve involvement. What will be your next action? First, they are mentioning something about a reaction. Okay, lepra reaction. If you see a lepra reaction, first point is whatever the thing happens, you have to continue the MDT. So these two options are out. Stop MDT is not the answer. So if the pre-existing lesions are enlarged and painful, yes, you are correct. It is type 1 lepra reaction. You see type 1 lepra reaction, the main thing you need to do is you have to give a systemic steroids. Thalidomide in type 2, as you know correctly. This is an important table. I will just fill in the blanks. The type 1 and type 2 lepra reactions are basically hypersensitivity reactions. Type 1 lepra reaction is a type 4 hypersensitivity. Type 2 lepra reaction is a type 3 hypersensitivity. You can remember something like 1 plus 4 is equal to 5. 2 plus 3 is equal to 5. Okay. Type 1 lepra reaction is commonly seen in all borderline groups. Type 2 lepra reaction or erythema nodosum leprosum is seen in lepromatous groups, BL and LL. If you see the skin lesions, type 1 lepra reaction, the existing patches will become red. In type 2 lepra reaction, there will be new painful red crops. If you see the nerve involvement, it is more severe in type 1, less in type 2. But all other systemic symptoms, something like a constitutional symptoms, systemic involvement like joint pain, iridocyclitis, orchitis, everything is severe in type 2. Okay, only nerve involvement is severe in type 1. The nerve will be severe in type 1. Others are severe in type 2. You see the statement, both the conditions MDT should be continued. For type 1 it is steroids, type 2 it is thalidomide. High dose oral clofazimine. Those are the treatment options. Okay. Alright. Now we'll see some important miscellaneous topics. They can give an image something like this. Like a lady presented with BMI of 30 with following clinical findings. What is the underlying cause? They are given an image of acanthosis nigricans, right? Here in the exam question, it is very clear. The BMI is more than 30 with such findings. So it is more towards metabolic syndrome. This acanthosis nigricans is seen in various conditions. Something like a metabolic syndrome, obesity, type 2 diabetes patients, even some cancers like gastric adenocarcinomas. Sometimes it can be congenital also. Congenital acanthosis nigricans also no. So the answer here is metabolic syndrome. There will be brown to black velvety flocks. Over neck, axilla, and other flexures like elbows, knees. So these are the points you have to remember. Next you will see something about the difference between anagen and telogen effluvium. We know effluvium means a diffuse hair fall. You won't see any patches of hair fall. You will see the entire hair is coming out in the hand, but the hair appears normal. Effluvium means a diffuse hair fall. Based on the predominant hair, you will call it as anagen effluvium or telogen effluvium. We know now there are three pairs of hair: anagen, catagen, and telogen. Anagen will grow, catagen will stop, telogen will fall. That is the basic hair cycle. If anagen is falling more, it is anagen effluvium. If telogen is falling more, it is telogen effluvium. The main thing we have to know is the trigger and basic pathomechanism and how much time lapse between the trigger and hair fall. In anagen effluvium, it is mainly due to radiotherapy and chemotherapy. The concept is very simple. Radiotherapy and chemotherapy affects the rapidly growing cells, like stem cells. So it will affect the rapidly growing type of hairs, which is another anagen hairs. So what will happen? The anagen will become dystrophic anagen. So this dystrophic anagen will fall off. This process will take a 3 weeks time. In telogen effluvium, what will happen? Something like any form of stress. It can be fever, it can be exam. In fever, it can be COVID, it can be influenza, it can be typhoid, anything, dengue, anything, or any exam, even postpartum period. What this stress will do, it will convert majority of the anagen and catagen hairs into telogen hairs. Right? These telogen hairs will fall off. This process is little bit slower. It will take 3 months. Between the trigger and hair fall, there will be a 3 months duration difference. You can note of it. This is the question. As in 2022, where the COVID was very famous topic. Na? A 30-year had a history of COVID 8 months back, presented with hair loss since 4 months. The diagnosis is, yes, it is telogen effluvium. In telogen effluvium and ananogen effluvium, you won't see a specific patches of hair fall. You will see only the diffuse hair fall. So the answer here is telogen effluvium. Correct. There is a 8 month and 4 months. If you subtract this, you will have 4 months latency. So it is a telogen effluvium, right? If they are giving a patient is receiving chemotherapy for a Hodgkin's lymphoma, developed hair fall, you have to think of antigen effluvium. Next question, a 65-year-old patient presented with erosions in the nasolabial area, histopathology shown, the diagnosis. You are seeing this bluishness, na? You will see basal cell carcinoma. It is very, very easy to remember. Blueness in dermis. B for B. Along with blueness, you will see peripheral palisading. And something like a retraction cleft, something like a gap seen here, na? Between the dermis and ness. These are retraction artifacts. Or retraction clefts, you will see. Very, very important. In basal cell carcinoma. Mainly it involves the nasolabial area and the cheeks. They have erosions with a beaded margin. Okay. Other few things you have to remember is a patient presented with such a red, round, whorly appearance. These are keratin pearls. Seen in squamous cell carcinoma. If you see such lymphocytes within the epidermis, these are quadrier microabscess. Within the epidermis, this epidermis, now within the epidermis, you are seeing such things. It is seen in cutaneous T cell lymphoma. Or otherwise known as mycosis fungoides. Perfect. These are other two important things you have done. Right? Next question. A obese lady presented with acne lesions, treated with oral antibiotics and isotretinoin, not responsive. What is the next step? First, you see the image. The image is showing the lesions are over the lower jaw region. Okay. And the second one, they are resistant acne because they are not responsive to antibiotic and isotretinoin, which are more powerful. And the lady is obese. If such findings are there, you have to think of a condition known as hormonal acne. In this condition, along with this, you can see female pattern hair loss and hirsutism. Hirsutism is presence of terminal hairs in a male distribution in a female. Okay. So, in this case, the best next step should be look for a hormonal evaluation. Something like a AMH, anti-mullerian hormone, FSH, LH, pre-testosterone. Dihydroepiandrosterone levels. Here you can see. When a lady, that too middle-aged lady, after 25 years, having lesions over lower jaw, hormonal problems, resistant acne, obesity, you have to think of a condition known as hyperandrogenism or hormonal acne. Right? Good. It is known as hyperandrogenism. The triad is. Right? Another important question asked in acne is treatment of choice for nodulocystic acne. They give nodulocystic acne, it is isotretinoin. Next, a patient is using ADA presented with itching and periorbital edema. What is the component causing this? Basically, they are telling the condition known as allergic contact dermatitis. Na? Allergic contact dermatitis. For hair dye, it is mainly PPD or paraphenylene diamide. Okay. For hair dye, it is mainly PPD. For cement, it is hexachromate. For former and forming, it is mainly parthenium. It's an allergic contact dermatitis. Can you tell me what test you can do to diagnose or identify the cause? What test you will do? Test, it is patch test. Based on type 4 hypersensitivity reaction. Read it 48, 96 and 7th day. 46 hour, 96 hour and 7th day. The best time is 96 hours. Best. Okay, these are very, very important. The test to diagnose is patch test. They will apply the allergens over the back and see the response. Right, a child presented with following skin lesions over the face. What is the likely complication? First, you will see what is the condition. It is giant congenital melanocytic nevus. If it is more than 20 centimeter. Yes, if it is a giant CMN, the main complication, mainly if it is involving the face, it is leading to malignant melanoma. Okay. Instead of this, they are giving a port vein stain, means you have to think of a glaucoma. They are giving a port vein stain. Means glaucoma. Can you tell me port vein stain glaucoma with the leptomeningeal angiomatosis? What is the diagnosis? Stag Weaver, perfect. Somebody is asking how to differentiate it from nevus of Vota and CMN. Nevus of Vota will be blue. Because it is dermal melanocytosis, so it will be blue with sclera involvement. Here the sclera is clear, na? So that is the differentiating feature. And in the CMN, you will have hairs, more hairs. That is also a differentiating feature. Black with hairs means it is CMN. If it is blue with sclera involvement means it is nevus of. Right? Main point I want to emphasize is CMN means you have to think of melanoma. If it is a port vein stain, you have to think of glaucoma because of Stag Weaver. Next question, which of the following is the most specific feature of juvenile dermatomyositis? Nail fold capillary changes, malar rash, photosensitivity, Gotran's papules. Yes, it is Gotran papules. Dermato means skin lesions. Myositis means proximal muscle weakness. In the dermatological things, you will see these papules in the knuckles. These are Gotran papules. Other findings of dermatomyositis are in the eyelids, you will see a rash known as heliotrope rash. In the chest, you will see a rash known as V sign. In the shoulder, it is known as shawl sign. In the thighs, it is known as Holster sign. These are the important signs in dermatomyositis. In the SLE, you will have a discoid lupus erythematosus rash. In the ear concha, you will see a ear concha. You will see a rash known as Schuster sign. And we all know the famous malar rash. What will be the finding in systemic sclerosis? You will see a salt and pepper pigmentation along with the tightening of skin. You will have salt and pepper pigmentation along with sclerosed skin. And you will see something known as calcinosis cutis. Means that skin will become thickened and there will be a calcium deposition over the elbows, knees and all. So that is another finding. Next, this is the last question. A construction occur presented with the whitish discoloration of fingers intermittently. What is the likely cause? It is because of the vibration the patient is having. Intermittent discoloration means they are telling something about Raynaud's phenomena. Raynaud's phenomena is seen in vibration related works. So we will see something about Raynaud's phenomena. It is divided into primary and secondary. Primary is idiopathic, secondary can be connected to related or work related. It is mainly transient and recurrent white discoloration of skin. The sequence will be there will be white, blue, red, WBR. The skin will become white first, then blue, then red. Mainly seen in fingers and toes. Associated with pain and burning sensation. If it is severe, it can lead to ulceration and gangrene. Yes, this is about the Raynaud phenomena. Thank you guys. I hope the class was useful.